Hi, I'm Rosalind Case. I'm a clinical psychologist in Melbourne, and I'm really pleased to be speaking to you today about the assessment and treatment of cognitive and psychological problems after cardiac arrest, which I fully appreciate is a massive topic, and I'm clearly not going to be able to do it justice today, but I do want to just be able to talk a little bit about the psychological outcomes of cardiac arrest and our approaches to assessing and intervening with those. Firstly, there's no such thing as a typical recovery. So some people will have a very smooth journey. They will find that they don't have residual cognitive issues or physical problems, pain, that they actually have positive emotional responses, that they're feeling really grateful and refocused on what's important in their life, and that they return to work with reasonable ease. But we know that it's actually a large proportion of people that experience challenges on the journey. So about 30 to 50% of people experience persistent or ongoing neurocognitive deficits. And by neurocognitive deficits, we're referring to often more subtle changes in memory, attention, how quickly we process information, executive function, which refers to things like organisation and planning, inhibiting behaviour, etc. And we see that a similar proportion seem to be at risk of increased mental health problems, including depression, anxiety and PTSD, but I don't think that captures it all. Often there are issues with adjustment that are not unique to cardiac arrest, but many individuals who've experienced medical trauma or a chronic illness and a critical care inpatient stay find that they experience this cluster of issues. And we know that family are impacted. There hasn't traditionally been a lot of research in this area. It's very pleasing to see that that's improving, but family might be at risk of PTSD, in particular because they're more likely to actually be witnessing cardiac arrest, potentially witnessing and even delivering CPR and going through the trauma of observing their loved one in ICU in an often very distressing state. There might be changes in terms of one's caregiver role at home and all of the things that come with that. And a lot of people talk about anxiety about a recurrent event and feeling afraid to leave their survivor loved one alone, and reluctant to let them get on with independent activities like exercising independently. So psychological care has to sit within the context of a wider system, and I really want to emphasise that post-discharge support pathways for cardiac arrest are not well developed, as most survivors and families may have encountered. Few health systems globally seem to provide comprehensive follow-up care, and this is different to what we see with arguably similar sorts of outcomes in relation to things like stroke and traumatic brain injury. It is really lovely to see some pleasing examples coming out of places like New York, our Essex group, Vicky Joshi and co in Denmark, and our lockdown version of post-arrest telehealth, which we're attempting to get off the ground here in Melbourne. And I think these are really great examples of clinicians just getting on with being creative, agile, and trying to be reflexive and listen to what survivors and their families say they need. I emphasise this because I think we can't possibly know what people need or how to support them in their recovery if we're not following them. And it seems, again, very patchwork. I might have people find me as a psychologist, which is great, but how many people don't? So ensuring that everybody has equal access to post-discharge follow-up support, and thus assessment and intervention for whatever issues might present over time is really important. Now, I've been asked to talk about psychological assessment and treatment. I'm not going to go massively into that today because I think that psychological assessment in itself is something we'll leave to the psychologists. But psychological screening, I think, is something that's important and interesting for everybody. So I differentiate the two. Psychological screening refers to the use of often brief measurement tools, like little questionnaires or things you might have filled out at the doctor's or in the hospital, and these are things I think we can use more often and earlier. So those might be measures of anxiety, depression, trauma, broad measures of cognitive state, and they may not be particularly sensitive. They may not pick up on more subtle issues, but they're certainly a good place to start. And I really advocate for use of these in hospital and beyond. And thankfully, we're so blessed with all the technology these days. Anybody can administer these things. They'll be scored automatically, and really very little kind of advanced interpretations needed. So as a psychologist in a hospital, I'm going in and out of ICU on the ward, and these things are really quick to administer. I have heard a few doctors say, oh, you know, they're time consuming, it's expensive. It's not. 2 minutes on an iPad, you can do things that 10 or 20 years ago you couldn't get done, which, you know, there's a whole other lecture on that. But this accessibility to brief tools is really important. The problem I think we have in cardiac arrest, as in many fields, is which ones. There are so many, and I just pop a few up here so people can see some examples. And this is great. It's nice to have lots of different screening tools, but a lot of them kind of measure the same thing. And what you see in the research is people using different tools, and that makes it difficult for us to really understand the cardiac arrest population. So there have been certainly recommendations and moves towards trying to develop a cardiac arrest based outcome measure that's patient reported or family reported, that tries to capture all of these areas that might be affected after cardiac arrest, like mood, like anxiety, post-traumatic stress, cognition, sleep, fatigue, etc. I personally am moving away from these kind of patchwork measures towards using iPad-based assessments, and in particular doing some collaboration at the moment with NIH, the National Institute of Health, around their NIH Toolbox and Promise tools, which you can tailor to a particular population. And I really like the idea that we can get those in multiple languages and translated, and maybe some consistency around the world about the tools that we use for that. I differentiate that from psychological assessment. I just want to make that point that psychological assessment is another thing. It's done by a psychologist. It's often very in-depth over multiple sessions, and it involves numerous tools. It may involve structured assessment tools, but they tend to be a lot more in-depth than the brief screening tools that you might use in other settings. So I think that brief screening tools are really great for identifying big problems. They might not capture everything, and beyond that, we can't assume from a person's score on the hospital anxiety depression scale why they are experiencing what they're experiencing in their particular context at this time, or what's keeping it going, what's making it worse, and how to treat it. So if we identify that people have these needs with screening tools, we need to actually be able to move beyond that and refer them for more in-depth or comprehensive support in those areas. And psychological assessment ideally is going to lead to, if not diagnosis, which is often appropriate but not always, to a comprehensive clinical formulation or case formulation, which is really a story informed by psychological theory and psychological research. And it helps us to understand, why is this person experiencing their current difficulties, with reference to a whole lot of relevant background factors, and importantly, identifying what are the perpetuating factors, what are the things keeping this going, because that's where we want to be intervening. So psychological treatment, I'd love to be able to sit here and say, here's 5 things you can do. I won't. The internet can can do that for you. One size does not fit all, and it's important that we do not confuse psychological treatment or interventions with strategies or tools. For example, mindfulness. If you go and see a psychologist and they tell you to download a mindfulness app, that's nice, that's lovely. My child could tell me to do that as well. That's not psychological treatment. It can be a useful adjunct. I don't think it's a bad thing, but if that's all that we give to people, that does not a psychological treatment make. So for many people with mild issues, you're going to get benefit from those sorts of low-level relaxation strategies, maybe some slow breathing. But if that's not enough, then don't stop there, because that's not even the beginning of what proper psychological assessment and treatment should involve. I'm going to speak very briefly about some of the primary forms of more in-depth psychological treatment that people with more significant issues might investigate. Neurorehabilitation has traditionally been tailored towards people with more serious disabilities, and we have a great deal of research in the field of stroke, for example, less so in the field of cardiac arrest. What we do know around neurorehabilitation is that those need to be tailored. Those are often focused around gross functions, so mobility, language, and they're delivered by multidisciplinary teams. The earlier the better, while there is still some plasticity in the brain. And yeah, it's really the goal is to optimise neurological recovery after a really severe brain incident. When it comes to mild cognitive impairment, there's not a lot of evidence for things like cognitive training. You might have seen ads on the TV for things like lumosity. The research is still developing there in terms of, yes, you might get better at playing a game on your phone, but does that translate to you being able to actually remember more things in your day-to-day life? But again, that is a developing field. I think it's an interesting one because it's potentially really accessible and cheap. We are running a little trial here in Melbourne on that at the moment, but it remains to be seen whether there are real benefits for people there. And cognitive behavioural therapy, I think, is a term a lot of people hear, CBT. Really, it's an umbrella term that refers to a range of evidence-based techniques that are focused around addressing unhelpful cognitions, thoughts, beliefs, and behavioural interventions. And these are gold standard for treating depression, anxiety, etc. Now, lots of therapists use other sorts of modalities like psychodynamic therapies, etc. I'm not going to talk about those today because I'm going to stick with the evidence, and the gold standard is CBT. So, which isn't to say people won't get benefit from those modalities, but in terms of what is going to give us our best shot at treating depression, anxiety, etc., CBT is it. Now, I want to just state again that I think those sorts of cases may not be in the majority. Not everyone's going to need a comprehensive psychological assessment and treatment after cardiac arrest. What we need, though, are systems that can tell us who does and then help us to find ways to link people in with those things. So the case, I think, is made for comprehensive post-discharge care systems to become a minimum requirement, to become a norm around the world. And when we look at what that minimum should entail, the literature's pointing us towards really clear information about cardiac arrest recovery that needs to be written, it needs to be understandable, and it needs to be realistic. Ideally, regular contact and follow-up with families and survivors for monitoring and support, and that might be a little bit more frequent and quite soon after discharge, but checking in 6 monthly even in the long term may be indicated for some families. And that would hopefully reveal opportunities for screening and referral. It also seems that families are really crying out for support, education and counselling options. We see massive benefits from our peer-to-peer support networks, and the lovely thing about really engaging with survivors and their families, particularly in the internet age, is that we can develop these systems and continue to adapt them in a way that is actually survivor informed, so that it's not just clinicians and researchers making assumptions about what people need in the long term. Thank you for listening to this talk, and I hope to be able to answer some of your questions after this.